Hi, my name is Jessica Durkee. I'm a clinical fellow in allergy and immunology from Children's National Medical Center and the National Institute of Allergy and Infectious Diseases. And it is my pleasure today to present to you our work looking at mortality and combined immunodeficiency from the USIDNET database. A moment of background. Combined immunodeficiency is characterized by decreased but not absent T cell immunity. And this is in contrast to severe combined immunodeficiency, which is characterized by absent T cell immunity, and common variable immunodeficiency, which is characterized by decreased B cell function and low immunoglobulin levels. This is a highly heterogeneous set of diseases, and we continue to look for populations with increased mortality that may benefit from early definitive therapy, most commonly with hematopoietic stem cell transplantation. Speckman et al. In 2016 recruited 51 patients who had profound combined immunodeficiency and atypical SCID. However, in their cohort, they were unable to identify genetic or basic measures of T cell immunity that predicted benefit from early hematopoietic stem cell transplantation. So what is this USIDNET? I'm sure you're all quite familiar, but USIDNET is a national clinical database of patients with immunodeficiency. There are 44 enrolling sites currently in the United States and Canada, and just under 5,500 enrolled patients. So our aims with this study were to characterize combined immunodeficiency as it currently stands and represented by the USIDNET database. And we wanted to understand the factors which may impact survival, including but not limited to demographics, laboratory values, genetic diagnosis, infections, comorbidities, and hematopoietic stem cell transplantation. So our methods were as follows. The USIDNET was queried for participants with a diagnosis of combined immunodeficiency as decided by the provider entering the information into the USIDNET database, or a genetic diagnosis consistent with combined immunodeficiency by the IUIS genetic classification. We excluded patients with primary thymic defects as they may benefit from thymic transplant over hematopoietic stem cell transplantation. And we excluded patients with Wiskott-Aldrich as those patients have been published with regard to outcomes from hematopoietic stem cell transplantation extensively. We categorized the comorbidities present in these patients by the organ system of involvement and by the kind of comorbidity, such as atopy or autoimmunity. And we also looked at infections both by the organism, viral versus bacterial versus fungal, as well as the severity of the infection being limited disease or disseminated and invasive disease. We subsetted the patients into profoundly lymphopenic and non-lymphopenic, with the profound lymphopenia definition presented here on your right, as put forth by Speckman et al. In their Jackie paper from 2016, looking at CD4 and CD8 stratifications as shown there. So here are our results. The baseline demographics of the cohort were as follows. We found a total of 337 patients within USIDNET who met our inclusion criteria. They were about a 50-50 split of male and female. 11% of the patient cohort, which was 38 patients, was deceased at the time of last known follow-up. The cohort was overwhelmingly Caucasian at 70%, although there was some representation of Hispanic Latino at 16%, and Black African American at 5%. There was a third of the cohort that met our definition of profound lymphopenia, with 12% having isolated CD4 lymphopenia, 4% having isolated CD8 lymphopenia, and about 20% having combined CD4 and CD8 lymphopenia. The age at key events are listed here. So the majority of patients had onset of illness before a year of age at a median of 6 months. Median diagnosis was 3.6 years. Median age of transplant was 14 years, with a wide interval of transplant at less than a year to years, and death occurred at a median of 20.7 years, with a minimum of 6 months and a maximum of 81 years. If we break down the genetics in this cohort, we had 81% that had one identified variant, 8% that had no identified causal variant, and 11% of the cohort had missing genetic information. And given our inclusion criteria, our cohort was enriched for patients with a genetic diagnosis. If we break down the 273 patients for whom a genetic diagnosis was determined, the most common genetic diagnoses were STAT3 at 18%, GATA2 at 17%, CD40 ligand at 14%, CTLA4 haploinsufficiency at 8%, and DOC8 at 7%. These patients were treated in a variety of ways. 1/3 of the cohort received hematopoietic stem cell transplantation at the time of last known follow-up, which was 98 patients. The majority of patients were on immunoglobulin therapy at some point during their treatment at 62%. And while information was only available in a minority of patients, 158, of those patients, 2/3 were on immunosuppressants for an indication that was not hematopoietic stem cell transplantation related. Here we compare genetic diagnoses in the patients that were deceased versus the cohort that was living. The percent of total cohort is here on your left, and the various genetic variants are across the x-axis. And these represent the most common variants in the cohort. STAT3 loss of function classical hyper IgE syndrome was the only comparison here that was statistically significantly different, with an increased odds of survival at the time of last known follow-up, with an odds ratio of 3.6. While these were not statistically significant, I will point out that CD40 ligand, DOC8, NEMO, cartilage hair hyperplasia, ataxia, telangiectasia, all had disproportionately high mortality. And I will also point out that the subset of patients with no identified causal variant did not seem to have increased mortality as compared with the cohort as a whole. If we look at infections, again, percent of cohort on your left axis and the kind of infection, percent of cohort on your y-axis, and breakdown of infections across your x-axis, mucocutaneous, fungal, non-specific viral infections were associated with an increased odds of survival, and that is in comparison to disseminated invasive fungal, disseminated invasive viral, and parasitic infections, which were all statistically significantly associated with decreased survival. And this is again on univariate analysis. Transplant was associated with increased mortality, which likely reflects patients with increased severity of disease and increased comorbidities being disproportionately taken to hematopoietic stem cell transplant. So here on your left, probability of survival is on your y-axis with an age of death across your x-axis. Transplanted patients are in the blue and non-transplanted in the red. And this was statistically significantly different, although I will point out that the curves diverged at about 20 years of age. Mortality was not different, however, in patients that were lymphopenic versus non-lymphopenic in the panel on your right. If we take a moment to look at the patients who were deceased at the time of last known follow-up, post-hematopoietic stem cell transplantation, those 18 patients are represented here. The most common genetic variants in this group were CD40 ligand, DOC8, and GATA2. And the most common causes of death were both graft versus host disease and infections. And I will point out here fungal sepsis and adenovirus being particularly prevalent in the cause of death. On this slide, the patients highlighted in this light plain color are patients who died from a clear transplant-related mortality. which was about 6 patients out of the 18 patients here. If we look at patients without hematopoietic stem cell transplantations, there are lessons to be learned here from the deceased cohort. 15 patients had died without hematopoietic stem cell transplant. 3 of those patients had CD40 ligand and 3 had CTLA-4 haploinsufficiency. 3 died of progressive multifocal leukoencephalopathy, and those patients had CTLA-4, NEMO, and CD40 ligand. The patient with CTLA-4 haploinsufficiency was the only patient of these 3 that was on immunosuppression at the time of developing PML. That patient was on sirolimus and prednisone. And the patient with CD40 ligand had attempted treatment with pembrolizumab, which was unfortunately unsuccessful. 4 patients died at older age, greater than 40 years of age. One of those patients was 74 with CTLA-4 haploinsufficiency, and one was 85 years of age with GATA2. Unfortunately, 1 patient died at a relatively young age with STAT3 loss of function hyper IgE syndrome, and that patient was deceased from massive hemoptysis. We then constructed a multivariable model to understand better how these different variables were interacting and leading to mortality, which resulted in the following. So we built this model using multiple included variables, including sex, absolute lymphocyte count, CD4 count, CD8 count, IVIG, genetic diagnoses, infections, and comorbidities. We then excluded individual variables that were extremely rare with less than 2 unique values or extremely unbalanced. Next, we applied the ECACI information criterion to select variables. And then finally, we did multiple logistic regression to obtain odds ratios for increased versus decreased odds of survival, and the results are listed here. STAT3 and GATA2 were both found to have an increased odds of survival as compared to the cohort as a whole, while neurologic disease, invasive bacterial, and disseminating invasive fungal infections all had decreased odds of survival on the multiple variable analysis. I will also point out here that autoimmune disease had a strong trend towards decreased survival, but it was not statistically significant. Other variables included in the model, but with extremely wide confidence intervals, were electrolytes, WHIM syndrome, PI3K, and STAT1. Here in the bottom right, I provide the receiver operating curve with sensitivity on your y-axis and specificity on your x-axis, which demonstrates that about 87% of the mortality in this cohort could be explained using this model. Some brief conclusions. We're able to construct a multiple variable model of mortality with invasive fungal and bacterial infections representing increased mortality, GATA2 and STAT3 associated with decreased mortality, as well as neurologic disease associated with increased mortality. Autoimmune diseases had a substantial trend towards increased mortality, but this was not statistically significant. And this may reflect findings that were previously shown in common variable immunodeficiency with worse outcomes with patients with autoimmune complications. Hematopoietic stem cell transplant was associated with increased mortality, but this needs to be taken with multiple caveats. Curves separated at greater than 20 years of age, which suggests that maybe early transplantation would be associated with improved survival. And I will also point out that transplant itself was not independently associated with increased mortality on a multiple variable analysis, despite being included as one of the variables for possible selection. It was not actually selected. And then similar to Speckman et al., we did find that basic laboratory values were not predictive of mortality outcomes. So I would like to acknowledge the patients and their family that enrolled in the trial, all of the providers that worked so hard to enroll all of this amazing data, the enrolling clinical sites, our team at USIDNET, including Dr. Sullivan, Dr. Marsh, and Hannah Wright, the group at Children's National, including Dr. Keller, and our statistician, Hua Wang, Pierre Figuier, being up at the NIH, entered an incredible number of these patients, and then the Duke University Clinical Research Training Program. Thank you.